Good afternoon. We have with us Dr. Ankur Bab, sir, critical care specialist from Spandan Multi-Speciality Hospital, Baroda. We welcome you to the Natco Pharma Specialty Criticon studio. And what we look forward during this time is your advice to the younger generation of doctors in the space of critical care associated with multibacterial resistance. My first question is, how do you foresee the changes in critical care management?
It's a very broad, very broad question. But in general, what challenges we are facing in the field of critical care is more and more infections are. We are getting more and more infection. Majority of them are multi-drug resistance, and majority of them are you're facing the challenge of managing the carbapenem resistant enterobacteriaceae. Another thing in India, we have uh, see more and more cases of poisoning, unaffordability, and unfortunately many of the patient, because of the poor financial resources, we are not able to manage in the way we should manage. uh, and of course in India, because of more and more people are driving, and we are getting lot of cases of trauma, multi trauma with very critical injuries, head injuries, and so on.
So you're seeing a lot of more rise in these cases, is right? Great. With regards to the young ICU doctors of the present time, what would be your biggest advice to them in enhancing patient care?
I think I would advise that, see, nowadays what we see is now a lot of physicians or clinicians see more of reports and they treat, even if patient is not having symptoms. If the reports are abnormal, they tend to treat it. So I think we should not treat the numbers and we should treat the patient. Sometimes we have very bad report, but patient is absolutely fine. So clinically correlate. Sometimes we have very normal report and patient is not doing well. So this is one of the very important aspect. Second, another thing is rationalization, not overdoing, not underdoing. Appropriate management of our antibiotic stewardship is very important. Not using carbapenems or BLBLI in just community acquired infection, though patient may be very critical, but using the carbapenems in community acquired infection is not at all going to be helpful. Rather, it increases a lot of incidence of MDR and XDR. Uh, Many times we see a lot of unauthorized, or the treatment which is not being proven is also being administered a lot of time. So considering the, because all these are very costly affairs, so sometimes rather it helping, it may just patient's pocket get exhausted very fast. So we should be very rational in doing any kind of treatment.
How much has the healthcare industry understood this pain point of treatment?
I think what is happening is that, uh, to be very frank, a lot of clinicians or doctors are biased by recent trials or whatever. Suppose some trials are published in very renowned journals. So instead of believing them, we should study more about those trials, in which condition trials were organized, in which countries, because it cannot be extrapolated same trial into our country and our population. So just not jumping into the newer therapies, but we should be very careful before implementation of those trials and findings into our population.
My final question to you is, what is the prevalence of carbapenems producing bacteria in your field, and which is the best treatment option?
It is really alarmingly increasing in any of the ICUs, including my ICU. So around, I would say 50 to 60% of the E. coli and Klebsiella, we are getting carbapenem resistance. So again, nowadays 2 to 3 strategies are very helpful. One is we have to do which genotype we are, like we should do carba R, means which genotype we are dealing with. Like if we are dealing with Oxa 48, then probably ceftazidime avibactam alone is fine. But if we are dealing with NDM sort of, then ceftazidime avibactam plus aztreonam is required. Or else we can also go with the polymyxins along with one of the other, either tigecycline, polymyxin plus tigecycline, or high dose carbapenem if MIC is less than 16. If MIC is more than 16, there is no point in using the carbapenems. So polymyxin along with phosphomycin or with minocycline or along with the tigecycline, we can consider.
Dr. Bhavsar, we thank you so much for your time, for being with us in the studio, and we wish you all the best in your practice.